Hello students, welcome to Concepts of Care for Patients with Non-Inflammatory Intestinal Conditions. So the first topic we are going to cover today from this chapter is intestinal obstruction. Okay, this is one of the most important concepts, and you really need to understand your material in order to provide proper care. This chapter is going to be long. I'm going to divide this chapter in different videos because my interest is that you really master the concepts. Okay, so just make a very fast review at home about the key terms: abdominal compartment, borborygmy, exploratory laparotomy, fecal occult blood test, hernias, intussusception, very important, irritable bowel syndrome. All these concepts you can review by yourself at home, okay? Because all of them we're gonna cover in this chapter. I want you to really emphasize your studying in intussusception, also into obstipation. Okay, it's another concept that I want you to master. Strangulated obstruction, for example, this is going to be related to the first topic that we're gonna review right now, which is obstruction, right? And basically volvulus. Okay, so these two topics you can review by yourself at home. Okay, let's start. Elimination concept. Intestinal obstruction. So the intestinal obstruction can be partial or complete and classified as mechanical or non-mechanical. This is going to be our first stop, something that we need to understand. Obstruction could be mechanical or non-mechanical. With either condition, elimination is compromised, meaning bowel movement, right, by this common and serious disorder. Mechanical obstruction, so we are covering right now the first subtype. Occurs when the bowel is physically blocked. So it's physically blocked, something that you can remove. It could be a tumor, it could be a mass, okay, by problems outside the intestine, like, for example, adhesions or in the bowel wall, Crohn's disease, okay, that we're going to explain further. But in Crohn's disease, you have mechanical damage of the colon, okay, you can see physically, or in the intestinal lumen, tumors. So again, it's going to be physically blocked by problems outside of the intestine. It could be adhesions, that's outside. Inside, it could be Crohn's disease or tumors. Okay, so those are physicals. Now, non-mechanical obstruction, also known as paralytic ileus, non-mechanical paralytic. When we talk about paralysis in any form, it's related to the nervous, right? The influence the nervous system has in our muscles. So we are talking about paralytic ileus, means there is some problem with the nervous system. Or functional obstruction, right? No mechanical obstruction, also known as paralytic or functional obstruction, does not involve a physical obstruction in or outside the intestine. Instead, peristalsis is decreased or absent because of neuromuscular, there you go, disturbance, okay? Neuromuscular, resulting in a slowing of the movement or a backup or intestinal contents. Okay. Resulting in a slowing of the movement, still is going to be some movement very slow, could be paralytic, then resuming, then paralytic again, okay? And or backup of intestinal contents. This is very dangerous, backup of intestinal contents. So there's going to find the small intestine or any part of the intestine is going to be working, suddenly it's going to stop. And when that happens, the content is going to go back. And then it's going to resume and then paralytic again. Okay? Intestinal contents are composed of ingested fluid, food, and saliva, gastric, pancreatic, and biliary secretions. So when we say gastric, we are talking about our gastric acid, hydrochloric acid, for example. In pancreatic, we are talking about lipase, amylase, protease, okay? And biliary, we are talking about our bile, okay? All these digestive enzymes and swallow air. So, for example, you are getting your lunch today and you are drinking some water with your food. Maybe it's a steak with French fries, rice, and salad. And that is going to be mixed with your saliva. And then your gastric is going to put some hydrochloric acid in order to digest all of that, and then the pancreatic is gonna work, the lipase is gonna work on your on your fry and your French fries and your fried steak, and then the amylase is gonna work on the French fries also, but the carbohydrate portions, and then your protease is gonna work on the steak. I'm just trying to break it down to make logic in your brain what enzymes work on that. And then the biliary is going to work on the fatty of the French fries, maybe the fatty of the dressing of the salad, maybe the fat of the steak, okay? And then you are going to have swallow air. Probably you're going to drink a diet soda. So it's carbonated, so it's going to be air, okay? All of that is going to be the intestinal content. Okay, so in both mechanical and non-mechanical obstruction, mechanical and non-mechanical, mechanical is a physical, you can see the obstruction, and non-mechanical is a neuromuscular disturbance. The intestines contents accumulate at and above the area of obstruction. At or above, meaning you have your intestinal contents are going through the esophagus, the stomach, then goes to the duodenal, and then there is a blockage, let's say at the beginning of the jejunum. So probably the obstruction at the beginning of the jejunum is gonna cause that the content is gonna go back to the duodenal. So the intestinal content accumulates at the beginning of the jejunum in this example, or above in the part of the duodenum, okay? The area of the obstruction. Here comes the most important. Abdominal distension results due to the inability of the intestine to absorb the contents and move the way through the intestinal. So when there is the obstruction, the content cannot go through that obstruction, right? To compensate for the delay, hello, peristalsis increases. So I have the obstruction at the point of the beginning of the jejunum, and the content cannot go through. So the peristalsis is going to increase, increase to move the intestinal content forward. This increase stimulates additional secretions, which then leads to further distension. So due to the increase in peristalsis, more enzymes and more products that are going to be released by the intestine in order to help that content to go through, okay, the abdominal distension is going to increase. So you're going to see a patient that the stomach, the abdomen is going to have a big volume, okay? Okay, plasma leaking into the peritoneal cavity. So this is what's happening. So now the abdomen is tight because the peristalsis, the intestinal content, and other enzymes are, increasing and are covering bigger space. So now the abdomen is tight. Remember that the abdomen has a huge vascularity. It's huge in vascularity. So if we are having all these liquids content, blah, 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 the peritoneal cavity is going to start to receive the leaking products not only from the gastrointestinal area, but also from the vascularity, okay? Because the vascular system is not going to be able to expand, right, in order to absorb the nutrients, because they don't have a space to expand, because that area is very distended and rigid. Okay, so now this content is going to start leaking in the peritoneal cavity, and fluid trapped in the intestinal lumen decrease the absorption of fluids and electrolytes into the vascular space, decrease the absorption of fluid and electrolytes into the vascular space. So those electrolytes by the food that we are supposed to absorb, right, it's not going to be absorbed because those arteries, those vascularity, they don't have a space to expand and absorb. So our magnesium, potassium, our calcium, our sodium contents coming from the food are going to start leaking into the peritoneal cavity instead of going to the vascular space. Okay, reduce circulatory blood volume. This is going to cause hypovolemia because we are not giving nutrients to the circulatory system, and electrolyte imbalances are going to occur. These two concepts are extremely important, extremely important. So you need to know that in case of the obstruction, circulatory blood volume is going to decrease, hypovolemia is going to appear, and electrolyte imbalances may occur. Okay, so plasma leaking, circulation alert. Yes, it's very important. Specific problems related to fluid and electrolyte imbalance and acid-base balance result. Okay, so acid-base balance means that the body balance between acidity and alkalinity is referred to as acid-base balance. The blood's acid-base balance is precisely controlled because even a minor deviation from the normal range can severely affect many organs. I'm going to explain this with little pearls and little apples. So, we have an acidity level in the stomach which is very acidic. In the moment we transfer to the duodenum, the acidic the pH is going to increase. So it's not the same level of acidity. Stomach is very acidic. It's number one, right? Actually, it's one. Acid is number one. When you go to the duodenum, problem is gonna become 3 or 4, pH of 3 or 4. But when you enter the jejunum and the ileus, it's gonna come towards to 7, so it's almost neutral. I gave you in the supplemental material a graphic. I'm gonna describe this graphic in the class. But you need to understand that the acid-base balance means that every single part of the gastrointestinal needs to maintain the level of acidity. In other words, if I have an obstruction at the level of the jejunum, which is going to have a pH between 5, 6, or 7, okay, I'm just making up numbers. I cannot remember the exact level of acidity. But if we have an obstruction, these contents are going to go back to the duodenum, which carries an acidity level of 3 or 4, let's say, right? And if the duodenum is not working properly, it's going to go back to the stomach, which is very acidic. And this is going to become a domino effect. So you have some contents carrying a pH level almost alkaline from the jejunum, going back to the duodenum, which is a pH level of 3 or 4, and then going back to the normal, to the stomach with a level of 1, and then going back to 3, 4, going back to 7. So these changes in the pH is going to damage the acid-base balance, meaning that it's not respecting the area of the pH of each organ. Each organ refers to a stomach, duodenum, and a jejunum. Do you understand? So that is the risk in affecting not only the fluid and electrolyte, but also the acid-base balance. Obstruction high in the small intestine causing a loss of gastric hydrochloric acid, which can lead to metabolic alkalosis. Okay, if we have obstruction in the small intestine, the small intestine, as I was telling you, is going to be more towards pH 7, so it's going to be more alkaline, right? causes a loss of gastric hydrochloric acid. So the content is coming from the stomach with hydrochloric acid, right? And this obstruction is going to cause a loss of that acid from the stomach. And that is going to lead to metabolic alkalosis because the small intestine itself is towards to alkaline side, okay? An obstruction below the duodenum but above the large bowel results in a loss of both acids and bases. Yes, acids from the stomach and bases from the intestine. So acid-base balance is usually compromised. Obstruction at the end of the small intestine and lower in the intestinal tract causes both causes loss of alkaline fluids, which can lead to metabolic acidosis. The most important here is that you understand the most important, because I see already, I can imagine your faces already. The most important is that you need to understand that each space in the gastrointestinal corresponds to a level, a specific level of pH. So when there is an imbalance in the transit of contents, you are going to cause an imbalance in the acid-base balance. Okay, that's the most important. And now, if hypovolemia is severe, right, because we know the fluid and everything is going to the peritoneus area, acute kidney injury or even death can occur, right? Bacterial peritonitis, because we are having these contents and fluids leaking in the peritoneal area. Bacterial peritonitis with or without perforation may also result. With closed loop obstruction, which is blockage into different areas, closed loop, that means there is an obstruction from point A to point B. Okay, for example, you can have an obstruction that starts in the beginning of the jejunum, and then there is another obstruction at the end of the jejunum, meaning the beginning of the ileum. So all the contents are going to be within the jejunum only, okay? Or a strangulated, so you have the closed loop obstruction, blockage into different areas, or a strangulated obstruction with compromised blood flow that can be life-threatening. It's strangulated. The risk for peritonitis infection is greatly increased. Now, etiology, let's move. Intestinal obstruction is caused by a variety of conditions and is associated with significant morbidity. So we have the ileum in the small intestine is the most common site. Okay, mechanical obstruction can result from, and we remember mechanical obstruction, we are talking about physical mass, right? Something that you can see physically, an adhesion, a mass, okay? So can result from addition, we mentioned this before, a scar, benign or malignant tumor, complication of appendicitis, yes, hernias, fecal impactions, especially in older adults. And there is we're going to speak about prevention of fecal impactions. Believe it or not, this is not only related to adults, other populations, and this is happening in all ages, okay? So I'm going to explain why later. Strictures due to Crohn's disease. A stricture of a colon is an area of narrowing in the intestine. It can be caused by repeated cycles of inflammation and healing, such in Crohn's disease, which result in scar tissue replacing the normal cells. So let's say we have the lumen has a diameter of 5 centimeters. Let's pretend, okay? I'm just giving you an example so you can understand. So in Crohn's disease, we are having the stricture, right? We are having this inflammation that is causing some damage in the mucosa, and then it's gonna heal. So this is going to cause a scar, okay? Now the lumen, because of the scar, instead of being 5, is gonna be 4. And then we have another episode of damage and healing. And now the lumen, instead of being 5, is going to be 3. So that's a stricture caused by Crohn's disease, okay? Intussusception. Intussusception means that part Okay, telescoping of a segment of the intestine within itself. And we're going to see a picture in this chapter in a few minutes. Volvulus, twisting of the intestines. Okay, and then we have, okay, the stricter. Okay, so I copy this twice, I think. Okay, no problem. Um, postoperative ileus, paralytic ileus, or non-mechanical obstruction. Remember, non-mechanical is because a neuromuscular, okay? Non-mechanical. Non start with the N, neuro. Mechanical, muscular. Non-mechanical, neuromuscular. Easy. Can get easier than that, okay? Is commonly caused by handling of the intestine during abdominal surgery. Patients with paralytic ileus or postoperative ileus lose intestinal function for a few hours to several days. Electrolyte disturbances, especially hypokalemia, right? So now you have to make sure you know your potassium levels, okay? Predispose the patient to this problem. Hypokalemia predispose the patient to this problem. Postoperative ileus can also be a consequence of peritonitis due to leakage of colonic contents. Yes, it's similar to the previous case. The only difference is that this is a neuromuscular disturbance, which causes severe irritation and triggers an inflammatory response and infection. Intestinal ischemia, okay, results when arterial or venous thrombosis. Remember, I told you the abdomen carries a huge amount of vascularity, okay? So when there is intestinal ischemia, means lack of circulation, therefore oxygenation, results when arterial or venous thrombosis or an embolus that could be trapped there decreases blood flow to or in the mesenteric blood vessels surrounding the tissues. Dr. Matalana, what is mesenteric? Okay, the mesentery is an organ that attaches the intestine to the posterior abdominal wall, and is formed by the double fold of peritoneum. It's kind of a like a, how can I describe this? It's like a muscle, but it's having a double fold, double layer, right? That helps all the organs to be attached to the back of the posterior abdominal wall. Okay, it helps in storing fat. Hello, the mesentery helps to storing fat and allowing blood vessels, lymphatics, and nerves. Okay, blood vessels, lymphatic, and nerves to supply the intestines among other functions. So the posterior abdominal wall, has a huge number of blood vessels, lymphatics, and nerves, and these are supplying the intestines. Let's go back to the test. So then we have it results when arterial or venous thrombosis, we were talking about intestinal ischemia, or an embolus. Okay, so we have a thrombus or an embolus that is stuck there and is provoking lack of circulation, lack of oxygen. That is why it's called ischemia. Decreases blood flow to in the mesenteric vessels surrounding the intestines. Okay, we got this concept. Now, severe insufficiency of blood supply can result in infarction. Severe insufficiency of blood supply can result in infarction of surrounding organs. Okay, so bowel infarction, gangrene, and eventually sepsis in septic shock if we have, of course, this ischemia in the intestines. So here we have the picture of the intussusception. You see it's a telescoping of the bowel inside, right? And then we have the volvulus. You see the twisting of the bowel. Wow, this is unbelievable. Can you believe the obstruction can cause this? Because the increased peristalsis, the bowel gets kind of crazy. They need to make these contents go through the obstruction, and the peristalsis increases, and sometimes it's not successful, right? Incidence and prevalence. The incidence and prevalence are not well known. Obstruction occurs when more commonly in patients who have had a bowel surgery and in those with intestinal tumors. Okay, older adults are the most likely group to have a bowel obstruction because in the elderly population, the peristalsis is slow peristalsis, right? That's why they have bowel obstruction. On top of the nutrition they have, which is not the best nutrition, often as a result of fecal impaction, there you go, or malignant tumor. That's good to know. Health promotion, disease prevention, excuse me. Okay, so physiology changes associated with aging decrease peristalsis and cause constipation in older adults. To this, so the older adult is having a poor nutrition, older adult is having a slow peristalsis, and on top of that, they have a low intake of fluids. Okay, so that's why there is constipation. If constipation is not treated or resolved, the older adult may develop a fecal impaction that causes an intestinal obstruction. Therefore, teach older adults ways to prevent constipation, including fluid intake, included increased fluid intake, regular exercise, which is your walking, at least with older adults, make them walk 6,000 steps a day. Okay, 6,000 steps at least. If they can do 10,000, make them do 10,000 3 times a week, not every day. Okay, depending on their habits and the constitution of the musculoskeletal they have. Okay, high fiber diet, which is raw, not cooked, is raw vegetables and fruit, raw salad, and that operates for everybody, even us nurses. Okay, everybody. A lot of fluids, regular exercise. In our cases, that we are between 25 to 40 years old, not me, but still, okay, you are supposed to walk your 10,000 steps a day, no matter what. High flow intakes, 10,000 steps a day, and also get your raw salad, okay? Raw salad, not cooked, okay? And then your raw fruits. And a stool softener if needed, and I'm going to speak about that later. Other health promotion strategies to prevent intestinal obstruction include regular colon health screening. Okay, if you're in the period within the prevention guidelines, 45 years old and above, unless you have family members with history of colon cancer, then your screening should start early. A high fiber diet and a healthy lifestyle is possible. This is NCLEX alert. Okay, the 3 factors I mentioned to prevent constipation, which is your high fiber, high intake of fluids, and your exercise. Those are NCLEX alert is mandatory. You need to know this is prevention. Okay, it's gonna come in NCLEX no matter what. Assessment. History, so you're going to ask the patient if the patient has history of GI disorders, surgeries, and treatments. Okay, question the patient about recent nausea and vomiting and the color of emesis. Okay, if it's bright red, if it's coming with green content, which could suggest a problem with the bile is green, right? Described as greenish yellow, bilious, or hematemesis. Perform a thorough pain assessment with particular attention to the onset, aggravating and alleviating factors, and patterns of rhythms of the pain. So for this, you are going to use your all cards mnemonic to assess for all the symptoms. Use your all cards per symptom. If the patient has a symptom of vomiting, you use the all cards. If the patient is having a symptom of diarrhea, then you use again the all cards for per symptom. Okay, Ask about elimination patterns, including the passage of flatus and the time, character and consistency. Single tooth, which is hiccups, is common with all type of intestinal obstruction. When an obstruction is suspected, keep the patient NPO and contact the primary health provider. My dear students, to let you know, if you're hearing in the back of this recording like automobiles or the rain, is because I am recording this video from my car, because today is Saturday and the family activities at home are really intense now. But I really want to focus on providing this material to you, so anywhere is good. Okay. What else? Then Also, you're going to assess for family history of colorectal cancer and ask about blood in the stool or change in bowel pattern. And again, you use your old card mnemonic. Body temperature, a temperature with or without guarding and tenderness, and a sustained elevation in pulse may indicate a strangulated obstruction, okay? Peritonitis or intestinal ischemia. Let me repeat that sentence. A temperature with or without guarding and tenderness, okay, means guarding and tenderness means that the patient is covering the abdomen and they are scared that you touch the abdomen, right? And a sustained elevation in pulse, meaning that there is tachycardia, and that is one of the symptoms, signs and symptoms of fever, right? Tachycardia may indicate that strangulated obstruction, okay, peritonitis or intestinal ischemia, fever, tachycardia, hypotension, increasing abdominal pain, abdominal rigidity, or a change in the color of the skin overlying the abdomen should be reported to the PCP immediately. So basically, if you find a patient with temperature, immediately you do all your other assessment. You take your vital, complete, full set of vitals, your blood pressure, your heart rate. I will even do my pulse ox. I will do everything, okay, to double check what's going on. Okay, physical assessment, signs and symptoms. The patient with mechanical obstruction of the small intestine often has mid-abdominal pain or cramping. Pain can be sporadic. If strangulation is present, the pain will become more localized and persistent. Vomiting is more profuse with obstruction in the proximal small intestine. May contain bile and mucus or be orange brown and foul smelling because of bacterial overgrowth with low ileal obstruction. There you go, huge hint. So if the vomiting has a foul smelling, that means there is bacterial overgrowth there, infection, okay? That is going to make a difference with other type of presentation, okay? Huge, that's good to know. Eclex alert, okay? Vomiting can result in a disruption of fluid and electrolyte balance. Of course, if they are vomiting the sodium, the potassium, and other contents. Obstipation, which is no passage of a stool, and failure to pass flatus are associated with complete obstruction. Diarrhea may be present with partial obstruction. So obstipation, I want to make a stop here. So we have constipation is defined as the infrequent passage of stools or difficulty slow transit with evacuation of stools, while obstipation denotes intractable constipation caused by prolonged retention of hard, dry feces. Defecation is impossible for the obstipated patient. So obstipation is the complete stop of bowel movement and elimination. No more elimination. But constipation is going to be infrequent passage, okay? You can have periods of normal passage, then slow bowel movement, and then you stop for a certain period, okay? So that's the difference. Mechanical colonic obstruction means that there is a physical obstruction, causes a mild intermittent colicky abdominal pain, Lower abdominal distension and obstipation may be present, of course, because there is something physical that is causing the obstruction. Or the patient may have ribbon-like stools if obstruction is partial. So let's say in the lumen there is a mass or something on the right side. So the left side is going to be open for the stool to go through, right? So that's why it's going to be ribbon-like stools, okay? Alteration in bowel patterns and blood in the stools may accompany the obstruction. Either reticulitis or colorectal cancer is the cause. Now, observe for abdominal distension. Peristaltic waves may be visible. Auscultate for proximal above the obstruction. Now here comes another concept that you need to be clear on this, okay? Need to be clear. Many students get confused with this. I'm going to start to review this concept. Auscultate the proximal above the obstruction, high-pitched bowel sounds, borborygmi, that's the name. High pitch is borborygmi, right? Which are associated with cramping early in the obstructive process as the intestine tries to push the mechanical obstruction forward. Meaning, you are going to hear high-pitched bowel sounds, borborygmi, when the obstruction is recent, okay? So when the obstruction is recent, you're going to hear high pitch because there is increased peristalsis, there is a lot of contents, movement, and okay, trying to help this intestinal content to grow through. High pitch. Now, during later stages of mechanical obstruction, that's why it's very important to do your auscultation every 2, 3, 4 hours. I was, even though the protocol of the hospital was every 4, I was kind of obsessed with doing my bowel sounds every 2, every 3 hours. Why? Because later stages of mechanical obstruction, bowel sounds are absent, especially distal to the obstruction. So when at the beginning, a person with mechanical obstruction is, you are going to hear above the obstruction, you're going to hear high-pitched borborygmi. Later, when the obstruction becomes, when the obstruction is permanent there for many hours, okay, or maybe a day or 2, you're going to have absent bowel sounds, absent, okay? And this is going to cause a lot of problems. It's life-threatening, okay? That's why I became very obsessed with assessing for bowel sounds. You need to report this. I've seen a couple of patients, elderly patients, die in the hospital because of lack of proper assessment, okay? Even I saw a patient reporting the constipation for a week to the primary healthcare provider, who was not smart enough to tell the patient to go to ER and to be assessed and diagnosed properly. After 3 days of visiting the PCP, the patient passed away. That's why bowel sounds needs to be assessed often, period. Protect your license, nurses. Protect the life of your patients, number 1. Do your job, number 2. Protect your license, number 3. I'm going to repeat it. Protect the life of the patients is number 1. Do your job is number 2. And protect your license is number 3. Okay? You don't want to have in your records. Believe me, you will not be able to sleep, even if your license was in perfect standard, right? Standard condition. You are not going to be able to sleep if you remember that episode over and over. I was not able enough to assess my patient properly. I'm telling you. Okay. In most types of non-mechanical obstruction, the pain is described as constant diffuse discomfort. Pain associated with obstruction caused by vascular insufficiency or infarction is usually severe and constant. That's the difference with mechanical obstruction, right? So this pain is constant diffuse comfort, okay? Make the difference there. Pain associated with obstruction caused by vascular insufficiency or infarction is usually severe and constant. Another difference, okay? No decreased bowel sounds when auscultating the abdomen in early obstruction and absent bowel sounds in later. Okay. Vomiting and gastric contents and bile is frequent, but the vomitus rarely has a full odor and is rarely profuse. That's another difference with mechanical obstruction, right? Because non-mechanical is neuromuscular. Okay. Now, we are going to analyze this table. They are giving you key features, a small bowel and large bowel differences. So you have in your small bowel obstruction, you're going to see visible peristalsis, and I want to share with you a video of visible peristalsis here. Okay, let's watch this video so you can understand. And you're going to see what to expect. Look at that. So you can tell that the obstruction is in the mid-abdomen, right? Above the umbilicus. Because it's going back and forth, back and forth. Cannot go through. It's in the small intestine in this area. So it cannot go through, goes back to the beginning of the union, and it's trying to go to the ileum. But you see, it never reaches the colon. Never. Okay? Good. So this is the visible peristaltic. A small bowel obstruction, nausea, and early profuse vomiting may contain fecal material because remember bacterial overgrowth. Obstipation means that there is no bowel movement. Severe fluid and electrolytes imbalance, and I explain what happened with this obstruction. You know, increased peristalsis, increased fluids and enzymes are going to be collected, so therefore they are going to be leaking in the peritoneum area, and that's why we are losing electrolytes. Metabolic alkalosis not always present, right? Now in large bowel we are going to have lower abdominal distension because it's more related to the colon. Minimal or no vomiting, of course, right? Because it needs to travel a long pathway to go back to the mouth. So it's minimal or no vomiting. Obstipation or ribbon-like stools, this is kind of different. If we have an obstruction that is going to be partial. No major fluid and electrolyte imbalances. No major fluid and electrolyte imbalances. And why? Because the colon only absorbs fluids. The colon does not absorb electrolytes, and there is no exchange of electrolytes and fluid like in the small intestine. Okay, and metabolic acidosis not always present. Let's move to laboratory assessment. There's no definitive laboratory test to confirm a diagnosis of mechanical or non-mechanical. White blood cell count are normal unless there is a strangulated obstruction, which is gonna cause bacterial overgrowth, infarction, or gangrene, of course. Hemoglobin, hematocrit, and blood urea nitrogen values are often elevated, your bune, indicating dehydration, of course, the leaking of fluid. Serum sodium chloride and potassium are typically decreased, and that's good to know. Know your electrolytes level, especially important related to the upper quadrant pain. That's good to know, okay? Okay. In general, even your white blood cell count and know your levels of bone and all that. Other diagnostic, abdominal CT scan or MRI, always distension with fluid and gas in the small intestine with the absence of gas in the colon indicates an obstruction in the small intestine. Abdominal ultrasound to evaluate the potential cause of the obstruction. Endoscopy could be sigmoidoscopy or colonoscopy may also be performed to determine the cause of the obstruction, except when perforation or complete obstruction is suspected. Now, analysis. The priority collaborative problem for patients with intestinal obstruction is potential for life-threatening complications due to reduced flow or blocked flow of intestinal contents. So what is the best practice for patients and quality care nursing care for patients who has intestinal obstruction? So you need to monitor your vital signs, especially blood pressure and pulse, which could be an indication for fluid balance, okay? Your vital signs for fluid balance. Assess the patient abdomen at least twice a day for bowel sounds, distension, and passage of flatus. Well, in my case, I will do it every 2-3 hours. You never know. You never know, okay? There is no set parameter. For all types of body, right? An elderly changes could be slow. Changes in a young adult could be faster, depending on the comorbidities. That's why I don't follow personally, me, Dr. Matalana. I don't follow patterns in auscultating bowel sounds. It's like depending, I see the face, how is the condition, the presentation, how is the appearance of the patient, what comorbidities, and I get obsessed with assessing every 2-3 hours. My team also, okay? Because you never know. Monitor fluid and electrolyte balance status, including laboratory values. Okay, that's why you need to know your potassium, your sodium, your WBCs, hematocrit, hemoglobin. Manage the patient who has a nasogastric tube. You must know how to assess your gasogastric tube. Is extremely important. Okay, monitor drainage to ensure tube patency. You never do the aspiration on the nasogastric tube, okay, when aspiration of contents when you are assessing bowel sounds. You need to stop the aspiration of the contents, okay? Please, some common sense. Ensure tube patency, check tube placement, irrigate tube as prescribed, maintain the patient on NPO status as per doctor's order, provide frequent mouth and nasal care, mandatory to prevent any type of pneumonia or any type of bacterial overgrowth. Mandatory. Even if you are at the end of your shift and you feel like you need to go home and you're giving report, if you have not done that in your shift, that's negligence. Listen to me careful. That's negligence. You go home when you finish all your tasks. You don't pass the baton on this particular task to the following nurse because you don't know if that nurse is going to do your mouth and nurse care plus her mouth and nurse care. Okay, you complete this. It could be life-threatening. Maintain the patient in a semi-fowler position is extremely important, okay, especially in fecal impaction. If a patient is having fecal impaction, you cannot put the patient on a supine position, okay, please, because the contents are gonna go backflow. Please, some common sense. Put the patient in semi-fowler position, okay, to prevent further complications. Give analgesics or pain as prescribed. Make the patient as comfortable as possible. Maintain IV therapy for fluid and electrolytes replacement. You know that we spoke about the fluid and electrolytes. Give albumin as prescribed for patients with postoperative ileus. So albumin reduces certain side effects of opioid medicine used to prevent pain after surgery. So the patient is going to receive pain medication for the surgery, right? So this pain medication is going to cause constipation. So you give albumipan to reduce certain side effects of opium medicine, like constipation. Some side effects of opium medicine, stomach pain, bloody constipation, can delay recovery after surgery. So if the patient is coming here for an obstruction, please give them albumipan so they don't have more problems with constipation, okay? Maintain parental nutrition if prescribed, okay? Parental nutrition. Okay, I'm gonna make a parenthesis here. This is a scary story. Scary story. So we have, okay, let me go first to the definition. Parental means outside of the digestive tract, whereas enteral nutrition is delivered through a tube to your stomach or the small intestine. Parental nutrition bypasses your entire digestive system from mouth to anus. So when you have an order for enteral nutrition, you are going to use a tube that is going to be connected to the stomach or the small intestine. So the enteral nutrition is going to enter the GI tract. Okay? Parental is going to be given by IV. So it's not entering the mouth, the esophagus, the stomach, the small. No. Parental is IV. I met a nurse in my first year as a nurse in a hospital while I was training. This experienced nurse was giving enteral nutrition through IV. She made a huge mistake. She gave enteral nutrition through IV and caused aspiration pneumonia, right? And then the patient died. Scared story. Nurses, we are not playing. We need to know our map and everything in between. You are handling the life of patients the same way you don't want to do your mouth care, the same way you don't want to do your turning and position to prevent ulcers, skin ulcers. The same way you don't know where to administer your enteral, your parental, right? The same way you don't want to auscultate your bowel sounds because you need to go home. The same way you don't want to put your stockings, okay, to prevent embolism, okay? All these are going to cause a problem with your license. You can lose your license. All this year you are spending studying nursing. Plus, the worst is that you have somebody else in your record that died because of your negligence. Make sure you know your medications. Make sure you know all this that I am emphasizing, and I am spending extra minutes. And I know you are, come on, Professor Matalana, this is my Saturday. I should be with my family. You know what? You selected this career, and I am expecting you to have compassion and responsibility towards your nursing interventions. So I don't care. I am here in my car doing my recordings for you. While it is a Saturday, my family is having activities at home. But for me, it's imperative and very important to teach you to be professional, to have compassion, and to follow your nursing intervention to the best of your ability and knowledge. Please, nurses. Okay? Okay, let's continue. So, generate solutions and take action, planning and implementation. Intervention are intended to identify the cause and relief of obstruction. Yes. Okay, the expected outcome is that the patient obstruction will resolve to restore normal bowel elimination, prevent potential life-threatening complication, and relieve pain. Okay, non-surgical. If the obstruction is partial and there is no evidence of strangulation or ischemia, so non-surgical management may be the treatment of choice. Elimination patterns are expected to resume. Let me share with you a case in which doctors didn't know they were facing an ischemia, okay, of the mesentery. I explained already what happened, right? So you need to know what happened. They didn't know how to diagnose. They didn't diagnose this correctly. So let's watch what happened. They made an